The next paper is the ROUX-EN-Y Fistulo Jejunostomy is a salvage procedure in patients with post-sleeve gastrectomy fistula midterm results by Dr. Chouillard from Beirut.
Thank you, Mr. Chairman. Ladies and gentlemen. May I have the slides? Okay. So I have no disclosure regarding this topic. We all know that the leak rate after sleeve gastrectomy is something between 1% and 8%. It averages 3 to 4% in many reports. Non-operative treatment is the rule in these leaks. However, sometimes we need to go to surgery, and surgery could be really very grave, with mortality approaching 3.3% if you do total gastrectomy. This is why we proposed a way of dealing with these leaks based on endoscopic management. And in case of failure only, and in chronic leaks, we went for this procedure, which is the ROUX-EN-Y Fistulo Jejunostomy, in order to take care of the chronic and really tenacious leak, which is resisting endoscopic surgery. And these are the measures of the loops we were using. And we have already reported the short-term results, and now I'm trying to share with you some of the midterm, I mean more than 1 year after surgery, regarding these patients. We started doing these procedures back in 2007, and we've got now 75 patients who have been taken care of for leaks, of whom 30 required ROUX-EN-Y Fistulo Jejunostomy, mainly women and mainly by laparoscopy. We lost 3 patients to follow up, so these data are focusing on 27 patients with 27 months also follow up between 1 year and more than 6 years already. So if you take a closer look on how patients are doing, we can see that 75% of these patients, 3/4 of these patients, are totally asymptomatic. Some of them have some GERD symptom, but really it's rather rare. And the mean BMI is 27. Remember, it's an average 27-month follow-up, which is quite good. But nobody is above 33 BMI. And the excess weight loss is good. We give all our patients, after this kind of surgery, multivitamin supplementation for 2 years, but some of them are still needing this. Moreover, some are needing vitamin D, which is very common in France, and calcium and B12. Rare are the patients, as a matter of fact, 1 out of 27 who have some forms of malabsorption, as we monitored everybody with creatoria and steatoria, looking for this loss of nitrogen in the stool. So if you take a look at endoscopy, we did it in 27 patients. 25 of them have what we call double permeability, which is 92% of patients, and only 2 patients have their fistula disappear like this. So if you take a look at what we see, you will see a jejunal outlet, and then you will see a gastric outlet. This is a typical of what we see on the long run after these procedures. So we have a double channel. And if you do endoscopy also, some of these patients, 14% of these patients, have mid-gastric stenosis, which is by definition for us the impossibility of going through an adult endoscope. But the pediatric endoscope always went there. And these patients represent 14% of the cases only. And if you do upper series or CT, you will always see something like this. You will have a double foregut, like a double foregut. When you go from the esophagus, you will see it simultaneously. You will have double tract, one to the left side, the gastric, and the other one is jejunal. We are currently finishing our data. So I don't want to give you incomplete data regarding manometry, gut hormones, gastric emptying scintigraphy panels, and stool sampling microbiology in the whole series of 27 patients in order to define more this curious montage more than 2 years after its realization. We had 3 more events. I will go through these rapidly. One of them is a mild exocrine pancreatic insufficiency. We treated the patient like in a ROUX-EN-Y gastric bypass like Crayon, which has exocrine pancreatic X-rays. But the patient had a past history of alcohol addiction prior to surgery. So what's the imputability? One never knows. The second one is bacterial endocarditis with streptococcus in a 27-year-old woman in whom we discovered that she had mild mitral prolapse. So imputability question mark. And the third one, which is less obvious, intermittent diarrhea in a patient who is needing prokinetics and antibiotics. Useless to say that we ruled out internal hernia by doing laparoscopy after CT scan. And we didn't find any internal hernia in this patient. So please let me conclude by saying this is a procedure that will give you what I call a definite remission of post-sleeve gastrectomy fistula, because the fistula never heals unless you do a total gastrectomy. Avoid total gastrectomy because it's associated to lots of mortality, and midterm assessment shows that no endoscopic abnormalities can be found, no significant malabsorption, and a good excess % weight loss. Still, these montages are not very well known, and we need more assays to try to define them better. Thank you.
Thank you very much. This very interesting paper is up for discussion. Let me start out by asking you, so when you hooked the ROUX-Y limb up to this leak, did you do a hand-sewn anastomosis? Did you enlarge the fistula? You know, what's your technique of that? How do you do that?
So at the meantime, we are talking here, the video has been shown in the exhibit hall. We do the anastomosis hand-sewn. We try just to debride the not very healthy tissue, but we do not do any effort to enlarge it to a number of centimeters or to wideness we pre-chosen. No, it's always hands-on, always hands-on.
Okay. Back microphone there.
Three questions for you. What did you find with their weight loss? Did they have marginal ulceration at the anastomosis of the gastric pouch? And did they reflux?
So as I said, symptoms of reflux only in 3% of patients. And no marginal ulcers because all the patients had endoscopy and we didn't find any ulcer. I'm speaking about the midterm. Some of these patients had ulcers in the immediate post-operative period, maybe 2 or 3 of them. But at 1 year, 2 years, there is nothing. They have completely normal endoscopic aspect.
What about weight loss?
They have a BMI of, an average BMI of 27. Nobody is above 32.4. And they are doing well regarding weight loss. And some of these are now beyond 5 years after this procedure. We don't have any weight regain according to the current definitions.
2 questions. One, so were these patients all stented preoperatively? What types of interventions were done before you decided to take them to the operating room?
You mean which fistulas goes to the operating room, right?
Correct.
There are 2 settings. Of course, the acute fistulas, where you have peritoneal sepsis and you need to do lavage and something like this. This is something else. We operate chronic fistulas, which failed 2 attempts at endoscopic treatment, which are beyond 6 months after their onset, and never acute or semi-acute or semi-recent fistula. It must be chronic. The most chronic fistula we operated on was 9 years after sleeve gastrectomy. It was a gastropleural fistula, and the lady got pregnant, and we operated her 9 years later with a gastropleural fistula.
And all these leaks, it looks like they were all at the G junction, is that right? Otherwise, you would have just done a
Yes,
regular
I must say 95%. Maybe we had one double leak with one upper leak and then one mediogastric leak, but the bulk of these leaks are at the GI junction.
We have one question from the electronic side. Why not do a circular stapled or linear stapled anastomosis?
This is a good question, because really we feel that we have not to fail this anastomosis. It's difficult to do a circular anastomosis on half esophagus, half gastric. Otherwise, you transform the operation into a total gastrectomy, which we try to avoid. And we want to take healthy tissue. We want to do it without any material that could stay here forever. So we use absorbable tissue, and it works well.
Thank you.
Thank you.